Welcome to Legacy Magazine presents Black Health, a weekly talk show discussing medical issues afflicting and impacting the Black community. Now introducing our host, Dr. Michelle Kirwan Blythewood.
Good afternoon. I am Dr. Kirwan Blythewood, and I am the host of Black Health. Welcome to Black Health. I am a board-certified pediatrician and the chief medical officer at the Pediatric and Family Health and Wellness Center in Miami Gardens, Florida. And today we are touching on a topic that I think is of great importance to many people, especially in this time of coming through a pandemic. We are talking about trauma. So if you or someone you know or love has experienced trauma, you definitely want to stay tuned today. And to talk to us about trauma today, we have Dr. Juandalyn Peters. Dr. Peters, welcome. It's a pleasure to have you here today.
Thanks, Dr. Kirwan. It's a pleasure to be with you.
So I'm going to go take a minute and introduce you into our audience. So Dr. Juandalyn Peters, was born and raised in Nassau, Bahamas. She graduated from the University of Miami School of Medicine and trained in adult and general psychiatry at Duke University Medical Center, North Carolina. She returned to Miami, where she did 2 years of child and adolescent psychiatry at University of Miami. She's board certified in general psychiatry as well as child and adolescent psychiatry, and is a fellow of the American Psychiatric, is recruiting you to my association, fellow of the American Psychiatric Association. You're also on faculty at the University of Miami School of Medicine. So Dr. Peters, we are talking about a topic today that I think is of great importance, especially in this day and age, especially in this country and really around the world. We're talking about trauma. So I would like to just start with, how do you define trauma?
I think, to put it as succinctly as possible, it's when somebody is exposed to actual or threatened death or serious injury or sexual violence. Okay,
so that's a broad range of topics. Talk to me about, we'll just take a little segue here. Talk to me about generational trauma. I know this is a controversial subject, but what is the definition of generational trauma, and why is there controversy about it?
It's the idea that that we can essentially be born with trauma, that exposure to our parents and grandparents, that our genes and the way that they're expressed can have changed because of the trauma that our ancestors experienced. And so particularly as African Americans exposed to systemic racism and violence and abuse of all sorts for generations, I think it's even more applicable to us, particularly when some of that trauma is ongoing. But it's not the idea that we inherited in genes per se, but that the way that our genes are expressed can be affected. And so I think it's controversial for two reasons. One is that it's hard to prove, but I think the other is that reparations would have a stronger case the day that we are able to prove it, wouldn't we? Wouldn't it? So that would make it in the self-interest of many organizations and individuals. Exactly, to have it be a problem. But we know that for sure when women are pregnant, for example, if they're stressed, the high levels of cortisol, which is one of the major stress hormones that the baby is bathed in, essentially can affect brain development and actually result in higher rates of things like autism, schizophrenia, and ADHD. So that part is much more proven. We're still trying to work on how much of what we call generational trauma is about genes versus, the environment that people are raised in, with hearing those stories and with parents who are themselves still affected by the trauma and therefore communicating and raising children in ways that are affected by that.
I watched a very interesting episode of Juandalyn Fix My Life, and there was just a lot of anger in it, in the youngest child and in the mother. And when she went back a few generations, the grandmother was either a child during slavery, but had been brought up close to slavery times, and it's just seemed to be that anger passed down. Like, this is the way I was raised, this is the way I raised my daughter, and it's the way she's raising her daughter. And when Juandalyn really dug back, it was this anger from days of slavery. So I thought that was very interesting and an interesting concept, but that's more environmental than genetics. So what are some of the most common causes of childhood trauma?
It can be a variety of things, right? But childhood abuse can take on the form of sexual abuse, physical abuse, exposure to domestic violence, neglect, or substance use in parents. I want to highlight that exposure to domestic violence piece, because a lot of parents feel like, so what if they saw us fight? They didn't get hurt. Nobody was throwing anything at them or firing any guns. But just the idea of watching the two authorities in your life look like they're about to kill each other is a horrifying experience for a child. And so that's a major abuse for children as well. And then when it comes to adults, some of the same stuff, but then of course we are out in the public more, right? So then we can be exposed to trauma by virtue of, contact with police, vicarious traumatization, by the things that we see on TV, discrimination in the workplace. And so there's more of it in that regard when it comes to adults, besides, domestic violence situations as well.
How do children express trauma differently than adults, because they can't express their feelings and so on? So how do they express it?
As with depression, for example, one of the big things that you'll see is irritability. A lot more of a tendency to get angry about little things that would not have bothered them in the past. And one of the things we see typically also is that younger children will play in a more disorganized way and often reenact the traumas. Like they'll get their dolls together and they'll show one doll beating up another or humping another or something like that, and that something happened without any words. Another issue is that they can regress, right? So an 8-year-old or a 6-year-old who was formerly toilet trained can start to have trouble with incontinence, not being able to take themselves to the bathroom, will become more clingy. They suddenly need to sleep with mom and dad, or just more dependency. So these are the ways, the red flags with children.
And how about adults? I think that might be easier to imagine, but how do adults typically express, or different ways? I might imagine it might be anger or personality. And
anger is like a key one. The irritability, as we talked about with kids, getting angry quickly, but that falls into the subgroup of symptoms called hyperarousal. So along with excessive anger, then people are hypervigilant, like always looking over the shoulder. Even people who can't recognize that something has happened to them. And this is when we think about generational stuff. This is that person who's always on guard. Like when you go into a restaurant, they have to know where the exit is, or they have to have their back to the wall and be able to see everything. So it's the sort of hypervigilant, looking over your shoulder, expecting something bad to happen. Part of hyperarousal is also inability to sleep or disturbed sleep. So insomnia, and sometimes that's caused by the class of symptoms called re-experiencing. So sleep may be disrupted by nightmares. It's nightmares when you're sleeping, or flashbacks, thinking about the incident again, intrusive memories about it when you don't want to, or just feeling like it's happening all over again. Like sometimes I remember a Vietnam vet that I worked with one time just hit the floor like suddenly out of the blue, and I'm just like, because the tire had blown out, but to him it wasn't a tire blowing out, it was the sound of gunshots in war. So it's like your body actually is reacting as if it's happening to you again. That's what a flashback is. So it's hyperarousal, re-experiencing. And then a big one that makes it difficult is avoidance. So people don't want to talk about it. So if they don't talk about it, the people around them are clueless as to what really happened, right? And they want to avoid people who remind them of maybe an assailant or something bad that happened to them. So that can make your world smaller and smaller. You don't want to go to places that remind you of it. You don't want to encounter any sounds or smells or anything that remind you of it. And so people's worlds begin to shrink. So those are the three major classes. But because of all of that as well, there's a tendency toward dysphoria or, depression. People can be really sad and have this sort of foreshortened sense of future. Like, I remember a 15-year-old boy one time, which is just 3 years away from graduation, asking him about what he wanted to do in college, what he wanted for a career. And he stunned me. And that's what started my search for trauma with him. It was like, what's the difference? I'm not going to be alive in like 5 years anyway. So why do I need to be working hard about college? So it's like, wow. So that foreshortened sense of future is a powerful thing. It's like it represents a life of no hope. So why should you be trying at school, etc., if you don't think you're going to live?
You mentioned hypervigilance earlier, and I find myself, I mean, I've not experienced trauma, but I find myself now with all the shootings, when I leave Target, I'm looking around to see if I see anything, suspicious looking. Or last night I was at Walgreens, and as I come out, I find myself searching parking lots to see if there is any suspicious looking person.
And that is trauma, though. It's a vicarious traumatization because we watch that stuff. So we have to be careful how much of it we see on the news, etc., because it does affect us.
In movie theaters, I'm looking to see where would I run if somebody should come in. Okay, so I guess I've suffered some trauma.
I think we all have.
How do you address and treat trauma in younger children who just, it's harder for them to have an understanding of what has happened to them? And so how do you address it? How do you treat it? Where do you begin if they can't really, express themselves so well?
If they're really young, like, preschool age, what we do is play therapy, and so we provide all of the setup and see what happens and guide them in certain directions, right? So when I was seeing people in person, I had like a big doll house, and we'd have puppets, and we'd have all of the dolls and furniture and so forth. And so you present multiracial dolls and see what happens. Like, you allow the child, for a long time, they will simply reenact exactly what happened. And as time goes on, you can start to kind of move the play towards a healthier or more empowering outcome. And that is helpful in healing the children, telling the story repeatedly and then going towards a better, more empowering ending, and educating them about, what to do next time so that there's help available.
That's interesting. And why multiracial dolls? Just out of curiosity.
Because I don't know about, if there's like a research basis for this, but my feeling is we all as kids felt more comfortable when our playthings, we could identify with them. So I don't want a Black child having only Asian dolls or white dolls or vice versa, because it might feel like, well, these people aren't the same as me. They don't understand. It can't be. How do I do this if I don't see something that looks like me?
Okay. What are some of the signs that someone of any age needs professional help or for mental health or for trauma?
I would take it down to the basics. Not that I'm a great believer in everything Freud said, but I think this definition was simplistic. It's the ability to love or work, right? So love meaning if the person is not able to engage in meaningful relationships, or their relationships are all fraught with trauma because of distrust and so forth. By the way, of course, traumatic experiences at the hands of people affects your ability to trust. So if the person is not able to form meaningful relationships, whether that's friendships or, sibling relationships, whatever it is. And then the other is work. So if they can't get along in the workplace, if they can't function, if they can't focus well enough, because having flashbacks, well, yeah, that would affect your ability to focus, right? Whether you're in school or at work. So if you can't perform your functions at work, if you can't, perform your role in the home as a mother or father, or if it's as a student, your job is to, a kid, your job is to do school. So if you can't function at school, those are the major things. We look at ability to function because people have lots of kind of quote unquote eccentricities and other symptoms, but if they function with them, okay, they're just a little different, but they're functioning. That doesn't mean they're mentally ill. But when you're not able to function, that's when we would say that there's mental illness.
So having come through, or mostly through a pandemic, there's been a lot of trauma, a lot of loss, a lot of grief, a lot of emotional, up and down roller coaster. So how do we deal with that? What do you tell them? How do you counsel people to deal with all the grief and loss and emotional trauma from the pandemic?
I think one of the biggest issues, particularly for us quote unquote strong Black women, is to even acknowledge that you're struggling with it, right? That it's a thing, it's an actual issue, that, yeah, you lost 4 people who were close to you in the pandemic and you weren't able to go to the funerals because of the limitations of travel or the size of funerals, etc. And so a lot of the grieving happened in isolation, and that's a problem. Normally there are hundreds of us maybe who would gather together at funerals or like memorial services for our loved ones. And when we couldn't do that, I think that kind of caused a protracted grieving process. And so one of the things is to acknowledge that you're still hurting and you're not through the grief with that person at all. And then to consider, what can we do now? Even if it was a year and a half ago, what can we do now? So can we have a memorial service where we can all meet at the graveside or a certain place or whatever? Can we do something in memory of that person, like get together a gift for an orphanage if they were into helping children, or plant a garden if that's what they were into at a schoolyard or something like that? What can we do to honor their memory as a group, since we didn't have that opportunity a year and a half or 2 years ago? I think that can be very powerful. And understanding, the stages of grief, teaching people about that, like denial, anger, bargaining, depression, acceptance, and saying that it's okay to be in flux at any time between any of those stages. It's okay. It's all normal. Like, I can't tell you, well, it's 8 months and 2 days. You should have been over it by now. Everybody's timeline is going to be different, and to allow ourselves a space to grieve and share that grief among people who love us and love the person who's died. I think those are all powerful things we can do.
Can you take the viewers through those stages?
Denial is the first.
Information about
we say it as denial as first, second, third, fourth stage, etc. But they can be in any order and they can be simultaneous, and we can go back and forth between them. But traditionally, we say the first is denial, like we don't want to acknowledge that this person really is gone. Anger, when you acknowledge that they're gone, and it's like, oh my God, like he was a Christian, how could God let that happen? Or he was a good man, I can't believe that, he did nothing wrong, it wasn't his fault. Bargaining, just bring him back, just save his life, even if he's been in a coma for 2 years, just save his life and I'll be good forever after and give all my money to the church. So that's bargaining. And then depression, when you recognize that, okay, it's not likely that they're ever coming back. And then acceptance, when you have a sense of peace about it and you can focus more on the good times that you had with the person and be grateful for the time you had.
Wow. Okay. Yeah, and you said you can go back and forth between stages.
Right. So this month you might be like, okay, I accept it, I'm good with it. And then you see something on the news, another incident of something similar to how that person died, for example, and all of a sudden you're angry all over again. And you might have to work through it all over again because it's a reminder.
So what can professionals do to help someone with symptoms of trauma or other mental health illnesses or issues?
I think the most important thing is that people seek professional help and get a proper evaluation, because sometimes, we might blame it on trauma or whatever specific mental illness, and there's more than one thing going on at a time. So the first thing is an evaluation, because sometimes somebody will look for all the world like they're just depressed, and you're like, okay, well, they had a hard life, they should be depressed. And it turns out, well, their thyroid wasn't functioning properly, or the person is severely anemic. So the first thing is to get a good evaluation, which will make sure that they're physically healthy as well, with labs, and if they haven't seen a doctor in 15 years, like some people, making sure that they get checked out. And then beyond that, kind of becoming more clear about what the diagnosis is and offering talk therapy first. Because not everybody should be on medications. And so psychotherapy of different types, predominantly cognitive behavioral therapy. And if necessary, I think of as a last resort, then medications as well.
Yeah, I know many times when I refer patients or suggest a referral to a psychiatrist or a psychologist, their first response is, I'm not taking medications. I'm not taking medications for depression or anxiety. So I often find myself telling them, there are other things that can be done. First, just go see if there's an issue. See if, you might need 2 sessions, you might need 5, you might need a year or 2 of therapy. You never know. And maybe medication never enters the picture. But I know that's a big fear of many people, that if I go, they're just going to want to put me on medication. And, you have the option, if they suggest it, you don't have to, the psychiatrist is not going to push the pill down your throat every time you go.
Exactly. But I think a lot of people have been scarred by knowing people who were probably over-medicated at some point. And so they think that whatever the pill is going to turn them into a zombie, like cousin Joe or somebody that they know. And it's not like that, everybody doesn't need medications, but judiciously applied, it should be able to allow you to function better, not worse, not sleeping all day or not being your normal personality. People think it's going to change me. I'm not going to be the same person. I'm like, it's going to be you, but better. And that's what people, need to know. But for those who really should be going to see somebody in a case of depression and really don't want to go at all, I think one of the biggest things that I try to stress is just exercise, right? Time and time and time again. The studies have been repeated that if you do 40 minutes of aerobic exercise 4 times a week, that is as good as an antidepressant for mild to moderate depression. Now, if you have severe depression and you're suicidal and you can't get out of your bed, that's different. But mild to moderate depression, just that amount of aerobic exercise can be like an antidepressant for you. So that's a good start.
Okay. What are some other healthy habits that can prevent or mitigate mental health issues?
Besides the exercise, the other big thing I do a lot of preaching about is sleep. Like sleep. Our culture treats it as if it's a luxury, not like an actual biological need. But every adult should be getting 6 to 8 hours of sleep at night, and teenagers should be getting 9 hours of sleep a night, and many of them are getting less than an adult. And if we don't get proper sleep, then we can't remember, we can't concentrate, and we're a lot more prone to being irritable and depressed. So guarding your sleep habits is important. And so I talk to people about like one primary rule. I think if there's anything most of us struggle with is putting down the screens. Technically, we should get rid of the screens 3 hours before bedtime. And people look at me like I'm from another planet when I say that. So I strive for at least an hour before bedtime that you put the screens down and you read a hard copy book, do a jigsaw puzzle, a crossword, or whatever it is you want to do, and then go to bed and to keep the screens out of bed. But you see news stories all the time about how melatonin is flying off the shelves. It's like the biggest moneymaker. But it's not that people have a deficiency of melatonin for the most part. It's that the screens are suppressing the melatonin that our brains normally release, right? When you pick up your screen and you try to use it right until you fall asleep, it's a losing battle, because the blue light from the screens is saying to your body, oh, it's daytime, it's morning, let's get up and about. So if you put the screen down, you give your own body time to release its natural melatonin, which we'll have enough of, so you can fall asleep and you can stop wasting your money on buying melatonin.
I tell you, I took melatonin. I took one of my husband's melatonin one time, and I had nightmares. I was running for my life all night.
Oh, no.
And I would never again. And interestingly, my brother had the same reaction. So melatonin doesn't work for me.
Maybe that's a genetic thing, but we shouldn't need it. If people would just have healthy habits, like I said, putting down the screens, but also using your bed only for sleep. Well, sleep and sex, nothing else. So that when we get into bed, our minds say, okay, well, this is where we are. This is what's supposed to happen right now. Because as a woman, you understand that if you're in an environment where the bathrooms aren't clean or you don't feel they're safe, you just think they're nasty, whatever it is, you can hold it, even though we shouldn't, we can hold it for 6 or 8 hours. But the minute you get to your door or someplace you know that the bathroom's clean enough to use, all of a sudden you're dancing, you can't hold it long enough to open the door. That's because our bodies know this is okay. We are at home now, we can let it go. In the same way, if you do nothing in your bed but sleep, every time you get in your bed, your brain will say, oh, time to shut off and go to sleep. It's training of our brains. Yeah.
I never thought of it like that. That's a great analogy. I used to not have a TV in my bedroom for years, and it was much, much, much better.
That's true. It's tempting as long as it's there. Well, I'll just do a little bit.
I used to have really good sleep hygiene. I can't say I have that anymore, but I'm working towards it.
Well, I'm not saying I do either, but we know what we should do. You know what I mean? If we're having a problem with it, before you go to a psychiatrist or the pharmacist and ask for something to sleep, fix the habits first, because fixing the habits is, number one, free. Number two, no side effects. You know what I mean? Sleep medications are flying off the shelf. Some people feel like I'm cheating them, like the first appointment, if I don't give them a sleep medication when they have horrible sleep habits. Fix that and come back. And if it doesn't work, then we can talk about giving you a prescription. But that should never be, the first thing that we do.
Yeah, I do find that sometimes people would prefer to pop a pill than to do the work necessary to get the outcome that they would would like to achieve. Are there any other healthy habits that you would
Oh,
recommend?
by the way, exercise helps with the sleep as well. Other healthy habits are things like meditation. I think sometimes, particularly in the Christian community, people think of that as like a new age thing that's just horrible and something to do with the devil, but it's not. It's just clearing your mind. It's clearing your mind and teaching your brain to calm down for a minute so that you can have clarity of thought. So I encourage people to start with as little as 3 to 5 minutes. Because I remember when I first started years ago, I was like, one eye open, like, what? It's only 4 minutes? And I thought it was 10 minutes. So to set a timer or use an app to start with only 3 or 5 minutes. And if it's done regularly, it is associated with better mental and physical health all around, better anxiety levels, better sleep, everything. So that's one of the healthy habits that all of us can engage in with a little bit of practice. And the last is nothing to do, it's something to avoid, and that is substances. It's like the enemy of the brain, right? So if I had a dime, for every teenager who says about marijuana, Dr. Peters is just an herb, I would be incredibly wealthy. But it's just an herb that, particularly when your brain is less than 25 years old, has bad effects. If the brain is continuing to develop until that point, forming connections between your nerve cells or neurons, and you send that haywire, then you're essentially not giving yourself the chance to have as developed a brain as you can. But also marijuana is often associated, besides poor concentration and memory issues, it's associated with anxiety attacks and psychosis, like losing touch with reality. And alcohol is associated with depression. So this is where it becomes important, not just like the generational trauma history, but knowing your family's medical history overall, but in particular, it's mental health history, right? So if, your uncle, your father, and your big brother had problems with substance use, then when you go off to college, even though everybody else in the dorm is doing it, you might not be okay to get involved in the binge drinking games. It will have potentially a different effect on you than all of the other people. If you had a family history of depression, same thing. You're a lot more prone to get depressed if you start doing heavy drinking. So it's important for us to know our family histories, and then we know how to conduct ourselves and to protect ourselves better. Because I think we all know by now, pretty much in the Black community, that if you have sickle cell trait, you probably shouldn't marry somebody who has sickle cell trait, etc. But the same kinds of rules apply to our family histories of mental health problems. Find out, and so you know how to protect yourself, especially with what runs in your family.
That's very important. We often think of family history as medical and not psychiatric.
Right.
We're coming close to the close on time here. I wanted to ask you one quick question, or maybe two more quick questions. How does being a person of faith help right now in this day and age?
I think that is huge for a couple of reasons. One of the biggest things is hope. That's my tagline on my website, all business cards, everything, that mental illnesses are treatable and there is hope. At least as a Christian, you know that there's hope, that you have you can be victorious over whatever it is because of your faith, because your belief in God helping you. But in addition to that, a prayer life has been shown repeatedly in research to help people as well. Because it's hard for me, I feel sorry when people don't have any belief at all, because it means you think you're your own higher power. Like, I would be so screwed if it all ended with me, if it was all up to me. Like, I'm thrilled to know that there's a higher power, somebody who knows more and is more powerful and all loving, even when I mess up. And if you're not a Christian, then you don't have that. And lastly, I think the support system, like having a church, or even if it's not a church, like a community of believers who you can call on to support you, to help you when you're too depressed to pray, they can pray for you or with you, that kind of thing. So I think all of those things give Christians a major advantage.
Well, amen to that. So Dr. Peters, where can somebody, or how can somebody who might be interested in coming to see you, how can they find you?
My website, because people call us shrinks anyway, I accept that. My website is shrinkpeters.com. It would be. And the phone number is there as well. It's common knowledge. Since it's on the internet, I'll say it. It's 786-255-0347.
And real quick, you wrote a book, How to
Stop a Suicide. Yeah.
Stop a Suicide. Tell us a little bit about that.
That was quite a few years ago. I think that was 2011. But the idea was because of a near tragedy in my family. I think that was my way of processing it, teaching people what signs to look for when somebody may be suicidal, and then if hopefully they survive the attempt, how to get through it yourself, how to get past it, because every suicide or suicide attempt has a ripple effect. So just as we know signs of like what to do for breast cancer to check, etc., we should know that if somebody starts talking about suicide or writing notes or giving away their belongings or is super depressed, then we should intervene immediately. I wanted people to know that.
Wow. That's amazing. And where can somebody find your book?
Online on Amazon.
Okay, wonderful. Well, Dr. Peters, thank you so much for your time. You have been a wealth of knowledge. It's been wonderful speaking with you on this topic that I think is so relevant in today's world. There's so much going on, so much in politics, the pandemic, race relations, a lot of trauma. Even like you said, just being a bystander, watching trauma can affect us and has affected me. So thank you for opening our eyes to some new thoughts and on this topic. I will close out the show by a word of thank you to our sponsors. I know you touched on marijuana, and we don't approve of that for teenagers. We know that its effects are not good for young people, but it does have a medical component where it can be of help. And Black Health is brought to you by FAMU Medical Marijuana Education and Research Institute. Get credible information and engage in a safe space to learn and talk about cannabis. Educate, learn, and talk about cannabis in Florida. FAMU Medical Marijuana Education and Research Institute. Again, thank you, Dr. Peters. Thank you to everybody out there watching. This is Black Health, and we will see you next week again on Black Health. Take care, everybody.